Got it.
Definitely thinking.
Oh, okay.
All right. Just want to make sure that we are. All right, here we go. All right. Hi, and welcome everyone to the 2023 PI conference. We will get started in just a moment. My name is Alyssa Creamer, and I'm the Senior Director of Education and Community Services at IDF, and I will be your moderator for today's session, Overview of the Immune System and Steps to Diagnosis. I am excited to welcome Dr. Joyce Yu, who will be presenting on this topic. There will be time for questions at the end of the presentation. Please submit any questions you have for the presenter in the Q&A section of the platform. Please remember that everyone's journey with PI is different and unique, so please only submit questions that are general and do not share any personal health information in the Q&A, as those questions will not be able to be read aloud. Today's session is sponsored by CSL Behring, and we are grateful for their ongoing support of our educational learning opportunities. Joyce Yu is an associate professor of pediatrics at Columbia University. She obtained her medical degree from Mount Sinai School of Medicine, now Icahn School of Medicine, and did her pediatric residency training at Northwestern University. She completed her allergy and immunology fellowship at the Mount Sinai School of Medicine and an additional postdoctoral research fellowship under Dr. Charlotte Cunningham Rundles, during which she studied toll-like receptor signaling and memory B-cell class switching in CVID patients. She has conducted research projects that were supported by NIH training grant and by USIDNet. Her current clinical and research interests are in food allergy and clinical immunodeficiency. She is the director of Food Allergy Clinic and is active in teaching medical students, residents, and fellows. Thank you and welcome, Dr. Yu.
Thank you. So I will get my slide sharing here. Here we go. And I will see here. Right here. And let me see if we can get this to present on the 1 second. Let me see. Are you able to see this? I'm trying to see if we can get the
Yep, I can see it just fine.
Very good. I'm trying to see if we can get the slides to come up. I think it's having a little bit of issue here. Sorry about that. Oh, here it goes. Oh, that was not it. Hold on a second. There we go. Perfect. So I hope everybody can see this. I wanted to thank the IDF for allowing me to present this overview of the immune system. It's when I want to talk about the immune system and some just touch on diagnosis and sort of the big overview of treatment. So there's a lot to pack in the next 25 minutes, so I'll just get going. So I just want to give you guys sort of a background in terms of how our immune system sort of functions normally. So normally, our immune system helps to fight infections. So they're looking for microbes, things that could be attacking our bodies to make us sick. And our immune system also helps to prevent our cells from attacking ourselves. So basically, it's surveilling for autoimmune cells. 3, our immune system helps to control abnormal cells from harming our normal cells. So for example, it's looking for cancer cells that may be fighting our normal cells and blocking out our normal cells from working normally. And finally, our immune system generally tends to self-regulate itself to maintain a balance, so you don't have an overactive immune system or an underactive immune system. So in terms of how you classify our immune system, there's definitely several different ways of classifying our immune system, but this is one of the big general classifications. So we think of it as our innate immune system and our adaptive immune system. Our immune system is really what you're born with. So it's basically what you come out of the womb with. It doesn't need any training. It's ready to go. It's a first-line defense against microbes. On the other hand, it doesn't have much of a memory of our past infections. And example components of our innate immune system are neutrophils, the monocytes, the NK cells, and complement. On the flip side, our adaptive immune system is the immune system that you're quote unquote not born with. So to clarify, it's not that you're not born with the adaptive immune system. You were born with the components of it. You're just not born with it functioning, ready to go and functioning perfectly at right then and there. So because it requires training. But once trained, it can provide a more second, but more prolonged and more focused line of defense against specific microbes and bugs. But because it does take requires the training and it's a little bit more focused, it does take some time to ramp up. But the good news with that is that it develops memory of those past infections. So if you had a viral infection in the past and you get the viral infection again, your adaptive immune system has a memory of like, oh, I remember that particular bug. I know exactly who to recruit to fight that particular viral infection. So that's how comes this particular part of the immune system is much more focused and much more efficient in getting rid of microbes that we may have been exposed to in the past. Common example components of this may include our T cells and our B cells. We'll go over that a little bit in later slides. And finally, our innate and our adaptive immune systems aren't just silos that work separately from each other. Our immune system does really work together. So our adaptive immune system, we think of it tends to be triggered by our innate immune system. So when it happens, when you get infection, our innate immune system sends up the first line of defense, and then it sends a signal to our adaptive immune system to say, hey, I'm fighting off this particular infection, or this is what's going on here. Come on, I'm recruiting you to come and help kind of pick up the tail end and keep the fight going. So this picture is from the IDF Patient Family Handbook. It depicts all the major organs of our immune system. So all these organs either contain or have immune cells or immune cells that go through them in terms of whether they help the immune cells to develop or help to train the immune cells. There are two major organs that are actually not depicted here. And there are the skin and our gastrointestinal tract. So our skin also contains within the skin immune cells that reside within the skin. And also immune cells pass through the skin as well too. And also the same thing goes for our gastrointestinal tract. Here, this picture depicts all the different cells of our immune system. And so what you want to take away from this is that most of our cells, all our cells actually come originally from the bone marrow. In the bone, there are these particular cells called stem cells. We call them pluripotent stem cells, which is a very fancy word for basically cells that have the potential to become anything that they're going to want to be, all depending on whatever signals they get. So they can become, in this picture here, they can become like B cells, they can go to the thymus, become T cells, or they can develop into neutrophils, monocytes, red blood cells, platelets. These cells can also go over here to become like skin cells, or they can become like a GI tract or hair cells. But here it depicts all the major cells of our immune system in terms of ones that will help fight off our microbes and help keep us healthy. So just want to focus briefly, just hone in a couple of the cells within our immune system. So here I want to just really focus on the T cells, the B cells, and the NK cells. These cells are part of what we call the lymphocytes, which are a subset of our immune cells here. These have gotten a lot of press recently, especially in the past few years with the pandemic. Our T cells are ones that develop in the thymus, and they're major players in fighting viral and fungal infection, as well as some bacterial infections. And they are big players in helping to regulate our immune system so we don't have an overactive or underactive immune system. The B cells develop in the bone marrow. So they come from the bone marrow like the T cells, but they stay in the bone marrow and they develop in the bone marrow. And they can also evolve into what we call these long-lasting plasma cells that can secrete antibodies forever and ever and ever indefinitely. But the B cells in and of themselves, if they don't become plasma cells, they can also make antibodies as well. As we all know from the past few years, antibodies are a very big player of our immune system to fight infections. And the last type of lymphocytes or immune cells I want to kind of focus here are NK cells, which are a type of lymphocytes. Again, like the B cells and T cells, they come from the bone marrow and they fight certain types of viruses, particularly ones, for example, EBV, CMV, or HPV. So they have a particular, focus on fighting particular types of viral infections. On the flip side, the other major class of our immune system are the antibodies. So here lists the major classes of antibodies. So we have, IG stands for immunoglobulin. So basically immunoglobulin G, A, M, and E. So you can think of like the acronym game here. So the IgE antibodies are the ones that are most predominantly, they play a part in causing allergies, for example, food allergies and cat allergies, but they can also fight particular type of infections, for example, parasites. But when we talk about a lot of our fungal and our bacterial and our viral infections, we think of our immunoglobulin G, A, and M classes here. The other major classes of antibodies that we have in our body are vaccination titers. So these are the antibodies that we generate when we get vaccinated. And so here we list a whole wide variety of vaccine titers that we often take to check and examine in patients when we're looking at evaluating someone for immunodeficiency. So we look at diphtheria and tetanus, like our measles, mumps, rubella, like our MMR shot, our chickenpox shot, as well as meningitis, and our Prevnar vaccines. And these vaccine titers help us determine not just do we have antibodies, but also kind of help us measure whether our antibody and our cell immune system are working together to function appropriately. And there are a whole variety of other proteins besides antibodies that are composed of our immune system as well too. They can include cytokines and chemokines and complement that I just mentioned before. The cytokines and the chemokines are very important proteins that can help in terms of regulating our immune system, and also helps with our immune system components talking to each other. So basically, there are signals that the immune cells send between each other to help tell one cell tell the other cell, this is what's happening. And you recruit these particular types of cells, or maybe you need to upregulate this particular pathway. And it helps our immune system sort of like coordinate together to fight infections, to fight cancer cells, to fight autoimmune cells, and so on and so forth. So what happens though when our immune system functions abnormally? So as I mentioned before, normally we fight infections. So when it doesn't work, we can't fight infections, and then we are at an increased risk for infections. If we can't prevent ourselves from attacking ourselves, then we end up with an increased risk for autoimmune disease, such as lupus, autoimmune thrombocytopenia, autoimmune hemolytic anemia. If we can't control our abnormal cells from harming our normal cells, then that puts us at increased risk for cancer or malignancies. And if our immune system cannot regulate itself to maintain its balance, then we become at increased risk for what we call immune dysregulation. So it's an imbalance of our immune system where some components are overactive or abnormally overactive, and some components are abnormally underactive. And so unfortunately, you get the worst of both worlds, where we could potentially have an increased risk for infection, but we have maybe increased risk for autoimmune disorders at the same time. So when we don't have a normally functioning immune system, we could have multiple problems at both ends of the kind of function. So what is an immunodeficiency? So immunodeficiency is a disease that's associated with these changes in the normal functions of the immune system, as I just listed before in the previous slide. We often classify these as primary or secondary. Primary deficiencies are often also called an inborn error of immunity, or IEI, because these are associated with variations in the genes that we're born with. So hence the word inborn. But be careful, because sometimes symptoms don't really develop until the adult years. So we may hear of inborn errors of immunity, which you would think are inborn, so implying that you can see this in young children, but sometimes these may present in older adults. And some maybe appear to be otherwise healthy, more or less, may appear to be healthy, but they are actually really evident that they have this error of immunity until they're older. Secondary immunodeficiencies are those that occur secondary to something else. For example, if you have a primary autoimmune disorder, or if you take a particular medication that affects your immune system as well as a side effect, then you can have a secondary immune deficiency. For example, if you're on steroids or something like that, that can cause a secondary immune deficiency. So the types of immune problems that patients present with, or that you can have, that we see are patients that come with unusual infections. And I'll kind of go over that in a little bit in a second. Maybe someone who has a lot of autoimmune disorder, a lot of autoimmune issues, a little bit kind of more than usual, or like a little bit seems to be out of the scope of what someone would think they would normally have. Or maybe someone who has malignancy that wasn't expected. Or someone who has evidence of immune dysregulation. So it seems like your immune system seems to be imbalanced, it's overactive, it's underactive, there's too much inflammation in certain areas, maybe too many infections, and all these abnormal immune issues all at the same time. So that could be a signal that you may have some sort of, so those would be an immune problem that you could present to your doctor with that might signal that you may have an underlying immune deficiency. So in terms of the diagnosis and testing, So when you go to see your doctor and you want to give immune deficiency, our patients come to us saying that, you know what, I get sick a lot. And so the question that we have to ask ourselves is this someone who's unlucky, who has lots of infections, or someone who has an underlying immune deficiency? So some red flags that may suggest that you have an underlying immune deficiency is someone who tends to get infection with unusual organisms. Someone who gets an ear infection, it's an ear infection. Or someone who says, I get, like a cold virus, like a cold flu, like a cold virus, like a flu virus. Those are bugs that people tend to get all the time. So those are not unusual. But if you get an infection with an unusual organism, for example, like a pneumocystis, which typically doesn't cause infections, then that might be a problem. Having increased frequency of infections could be a sign. Having unusual severity of these infections. So maybe an ear infection that became very complicated, has secondary complications to it, that might be a red flag. Or infections that have an unusually prolonged course. So if you think of someone who has a head cold, they may get over in a couple of days, they should be fine. But someone says, you know what, I get sick and I'm down and out for the count for like weeks on end, maybe there's something going on. Maybe have unexpected complications, like I just mentioned before. Maybe someone who has an ear infection. The ear infection should just get treated with antibiotics and go away. But what if it becomes like a bone infection? What if it becomes like a meningitis? Then that might be a red flag for something going on. Someone who may need systemic treatments, for example, is not just oral antibiotics. You needed IV antibiotics. You need to prolong antibiotics to kind of to treat the infection. That could be a red flag as well too. And having involvement in multiple sites. So examples of this may be someone who has recurrent pneumonias, or someone who had a meningitis, or a bone infection, or infection in a joint like a septic arthritis, or having lots of abscesses. These may be indicators that maybe you have an underlying immune deficiency versus someone who's just been unlucky and had lots of infections.
Dr. Yu, can I have you pause for a minute?
Mm-hmm.
Everyone is loving your presentation, but they're asking if you can slow down a little bit.
Oh, okay, no problem.
It's great information and they want to make sure that they're getting all of it. So thank you.
No problem. I get very excited when I talk. So, other red flag symptoms. So red flag symptoms. So one of the cardinal signs of immune deficiency is someone who is predisposed to getting lots of infections, just like I mentioned in the previous slide. But you can have other symptoms as well that can be red flags for having immune deficiency as well. So things that you may not think about is, for example, someone who has, especially in children, someone who has poor growth, or we call it failure to thrive, or maybe an adult who is not gaining weight, so are having lots of weight loss, right? So, or sudden weight loss, that may be a sign of something going on. Chronic diarrhea may be a red flag symptom. Having hair and nail abnormalities. Or, for example, having a reaction transfusion. So most people don't really get blood transfusions, but if you were to have gotten a blood transfusion and you had some sort of reaction to it, that might be a signal that we might want to look into your immune system to see what's going on. If you had an adverse reaction to a vaccine, so especially the example here is the live vaccines. For example, if you got the chickenpox vaccine and you had a very bad chickenpox infection after the vaccine, then that might be a red flag that something might not be quite right. Or if you have a lot of autoimmune disease, so someone who has like colitis, like some sort of inflammatory bowel disease, or someone who has the hemolytic anemia, or the low platelets or thrombocytopenia. Now, I just mentioned before, you can get a secondary immune deficiency from a primary autoimmune disorder, but sometimes the reverse can happen where you have the underlying immune deficiency, and secondary to the immune deficiency, you can have the autoimmune disorder as well. So sometimes it may take a little bit of investigation to determine which came first, or which is the primary problem. So in terms of the initial steps of the diagnosis, all of this I was just telling before in terms of the types of infections, how bad your infections were, what other symptoms you may have, all these are very helpful for us to take a clinical history. And it's probably the most important piece of data that we have in order for us to help you, for immunologists to help you determine whether you have immune deficiency. So it's very important to keep track of all your symptoms and all your illnesses, when you were treated, why you were treated, how you were treated, how you responded to the treatment. All these are very important pieces of data that we need to know. Now, think about it. Lots of patients have gone to multiple different doctors, may have multiple different specialists, but you're the common theme between all these different doctors. So it really is helpful for you to try to kind of keep track, keep a diary, either on your phone or write it down in some notebook as to when all these different things happen to you. It's also important for you to obtain prior medical records, get copies from your other doctors. I know sometimes that can be difficult, but again, you can also try to keep records on your, like a journal or something like that, as to when these things happen. But it does help to have prior medical records for us to see, so we can sort of get an idea of like when things happen and how things were managed, how they were treated. And then finally, the reason why we do all of this is because, and when you go see an immunologist to begin with, the first visit may be very long, maybe just simply discussing your prior history. Well, why? Because the types of symptoms that you have and the types of infections that you have may help us to suggest a specific diagnosis even before we get to the testing, actually. And how is that? Well, if you're looking at examples of types of immunodeficiency by infections, for example, someone could say, I got infections, several infections with staph, or I had infections with this particular type of fungus. And by having a history of having these types of infections, it may indicate that you have a problem with your neutrophils. Someone may say, hey, you know what? I got lots of streptococcal infections. I had a couple enteroviral infections. Could this be a problem with my B cells or my humoral or my antibody compartment? If you had infections with, for example, like the PJP, the pneumocystis, certain types of viruses, that may suggest a particular type of immune deficiency with your T cells, and so on and so forth. But the most important thing is here, which is kind of hidden down here, the immune system is redundant. So it's not as if to say, oh, I have infection with this particular type of bacteria, it must just be this particular disorder. So that because we have so much redundancy, it may be multiple areas that may be affected. Or for example, maybe one area is abnormal, but it's being compensated for by something else as well. So the initial tests that we do, so we do our history, we see if our history suggests what may be going on with the immune system, and then we do our testing here. So in terms of our initial tests, we really do basic tests, and they can be very helpful. We do our CBC and differential, otherwise known as our blood count. So we're looking at your white cell count, we look at your red blood cell count, we look at your platelets. Even though people don't think of the red blood cells or platelets as part of immune testing, they can be helpful because they can help us determine, like where some of the initial problems may be originating from. Is it coming from the bone marrow? Is it coming from somewhere else in the body? We also look at lymphocyte subset counts. So remember the cells that sort of we're kind of focusing on earlier in the previous slide with the T cells and the B cells and NK cells. We look to see how many cells you have. So all of these tests between the CBC and the differential and the lymphocyte subset counts are looking at how many cells, right? So we're looking at two major areas, the function and the number here. So here we're looking at the number, and then we're also looking at we can also do some functional tests to see whether your cells are working. The next test that we look at is the quantitative immunoglobulins. So remember I was telling you about your IG, immunoglobulin G, A, M, and E classes. So we look to see how many antibodies that you have. Like, are we looking at the number? How much do you have actually? Then we also look at your vaccination titers. And what's important about your vaccination titers is not just the number or the quantity, but that having the presence of these titers also is an indicator of how well your immune system is functioning. So it helps us determine whether the cells and the antibody producing cells are interacting with each other and they're functioning to make these vaccination titers. So this is one kind of measure of your function of your immune system. So some additional tests that we sometimes tend to look at, and it depends on the situation. We also look at all your radiographic imaging. So for example, any prior x-rays, CAT scans, MRIs. We also look if you have any cultures that were done, so especially blood cultures, sputum cultures, urine and stool cultures, because again, depending on if you were to have positive cultures, whatever is growing in those cultures may help us to determine whether point us in a particular direction in terms of which part of the immune system is not working so well. And then here, this is a very big overview slide here. Once we do our initial tests, our initial blood counts, we look at our initial antibodies, we look at your overall number, we look at your overall function, then we may have to do additional tests that can assess specific pathways or functions. And here just really lists very, very limited examples. For example, the DHR, the dihydrorhodamine test. This is a particular test to look at neutrophil function, for example, in diagnosing someone with chronic granulomatous disease. This test here, the CD40 ligand flow cytometry. So I just wanted you to focus on these two words, the flow cytometry. So this is a type of assay that looks at cells and receptors and proteins on a cell surface. and on the outside of a cell, and that helps us identify what types of cells you have, whether the cell's functioning. So that tells us, like, quantifies, do you have the normal, the complement of cells like we have, or are those particular cells actually working? This particular type of flow cytometry is looking specifically for the CD40 ligand marker, and that's what is abnormal in patients with hyper IgM. But again, we use flow cytometry in looking at all these other types of immune cells that you have, like your T cells, your NK cells, and your B cells. We also have tests to look for complement. We look at cytokine panels and many, many other types of specific specialized tests that can look for specific pathways that may be abnormal, that may not be working so well, and that may help us to better determine how to manage or treat your immune deficiency. And then the question we often get is, like, so when do we decide to do genetic testing? So it's become more and more commonplace now to do genetic testing. Well, we get a large constellation of symptoms that don't point to a specific disease. So, we do our general immunology testing that I just mentioned in the previous slides. We look at your blood counts. We look at your cell counts. We look at your antibodies. We do some specific tests to look for specific pathways, and nothing's really pointing to anything. In which case, potentially finding that specific gene or protein defect by looking at your genetic testing may help us determine what is going on with you or what's causing your symptoms, and it may help us determine what sort of therapy may help. Now, again, the insurance coverage for this can vary, but the coverage is improving. It used to be years ago, it was very hard to get genetic testing, but now more and more insurances are covering this, and we do have special programs that some of these companies provide that can help cover costs. And in terms of the types of genetic tests here, so this is a big kind of overview of sort of the major kind of genetic tests that we use. And what the point of the genetic tests are doing is they're looking for changes or variations in our DNA sequence that may result in an abnormal protein, which is the functional part of our immune system that helps act to do things, basically. So the four major types of genetic tests that we look at are chromosomal microarrays, which are looking for big chunks of missing pieces of our DNA. Obviously, that would not be so good. We look at gene panels, so it's looking at a specific panel of genes that we think might be involved in causing the symptoms that you're having. We look at whole exome sequencing, which looks at the parts of the DNA that code for those proteins that are what activates, that causes your cells to be activated and kind of helps our immune system do what it needs to do. Then we also have what we call whole genome sequencing, which is looking all of the DNA. So all the regions, not just the regions that may be coding for a protein that's the activating part of the immune system, but also looks at the part of the DNA that doesn't really code for any particular proteins, but may have sort of by function to kind of modulate or kind of affect those other parts of the DNA. And in terms of this cost, just so you have an idea, so the whole genome sequencing is definitely much more expensive than the whole exome sequencing, which is much more expensive than the gene panel. But again, in general, the cost, now that these genetic tests are becoming more and more utilized, the costs for these tests are starting to come down. So in terms of the big overview of treatment options here, so we do have treatment options to help you manage immune deficiency. So one, the big one that everyone knows about, are antibiotics. And we use antibiotics in two major ways. We treat infections and we use them prophylactically. So for each infection that you have, we give you treatment antibiotics. But we also use antibiotics prophylactically as a preventative way to prevent you from getting infections, or if you were to get infections, to prevent you from getting so sick with infection. We also have what we call immunoglobulin replacement therapy, which probably everyone knows better as IVIG, or sub-Q IG, or otherwise known as gamma globulin. So what this is basically immunoglobulins or antibodies that are pulled from donors, and we infuse those into you, and it helps to make up for any antibody deficiency that you may have, or it may be additional immunity that we can provide to you passively to help fight infections, help modulate or help regulate the immune system. We also have now a whole large area of what we call biologic drugs, and I put it down here in quotes, pathway specific. So these are biologic drugs. We call it, they're modulators. They help they're very specific for very specific immune pathways. So if you knew this particular pathway wasn't working well, and if there's a particular component that's not working so well, we could potentially either block the component or we could replace that component, basically. So there's a whole large area of research into this, and it helps what we call like personalized therapy. And then finally, there's also lifestyle changes. So people think about treatments like antibiotics and gamma globulin, but also don't forget there's lifestyle changes that you would want to employ to help minimize your risk for infections. For example, if you're at risk for getting infection from water, you might want to be more cognizant to drink bottled water. You might want to avoid doing activities that may increase your risk for exposure to fungal infections. And you also want to do lifestyle changes that can overall help improve your overall general health and well-being. For example, like exercises, eating healthy. And you also do want to make sure to manage your other medical problems. So for example, you could go on your treatment antibiotics and you can minimize your risk for infections, but what if you still have your heart issues? Or what if you have your stomach issues? All of those other medical problems can still help contribute to you not feeling well. So you still want to get those managed as well too. And finally, how do you find an immunologist? So your first point of contact would be asking your primary care doctor or your specialist that you've gone to. And sometimes, but they may not know someone, or there may be someone not in the area where you are. So you can go to the either IDF website, the primeimmune.org, and you can click their Find a Clinician link, or you can also go to Clinical Immunology Society, where they have a Find an Immunologist link. You can enter your location, your city, your state, and your radius of your search radius, and they should be able to help you find someone that you might be able to contact in order to connect you to someone who might be an immunologist that may help you with determining whether you have immune deficiency or not. And finally, just a little plug for the Patient and Family Handbook, which is a very good recommended reference. So those diagrams came from the Patient and Family Handbook, and there is a nice overview of the immune system in there as well. And in addition, there's also sections in the Patient and Family Handbook on very specific immune deficiencies as well, which is a very good kind of overview and kind of is a launching pad for you to in terms of learning more about immune deficiency. So just want to say thank you.
All right, thank you so much, Dr. Yu. You took something that is very complex and you broke it down into some bite-sized pieces. So I definitely, even though I work for IDF, I found it really helpful from my perspective to hear all that you had to share with us. So thank you very much. We do now have some time for Q&A, but before we begin, I just want to remind everyone to please remember that everyone's treatment and condition and journey with PI is unique. The information presented during this session is not medical advice, and nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Please always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. And we have a ton of questions that have been submitted for Dr. Yu in the Q&A. There are over 20, so I'm going to try my best to get through them all very quickly. But I also just want to point out, if we do not get to your question, you can always ask IDF. If you go to our website, primeimmune.org, and click on the purple button up at the top, you can write in your question to IDF and you'll get a personalized response in the next couple of days after our conference. All right, so Dr. Yu, we're going to start with an easy one. How and why has our understanding of immune dysregulation versus primary immune deficiency changed in recent years?
So I think we are starting to recognize that primary deficiency used to be considered a deficiency, just a deficiency. But now we realize that primary deficiency is not just that. It's probably really almost all of these immunodeficiencies, I hope I'm on camera here and in air quotes here, really are probably some sort of dysregulation of some sort. There may be, so now there are some disorders where there's clear-cut dysregulation, where you have clear-cut over and underactive immune function. And there may be some primary deficiencies or PIDs that may have primarily just a deficiency. But in all of these, whether you're over and underactive, that's a disequilibrium, right? So you're not able to self-regulate yourself. So technically, by definition, all of these are probably have some at baseline, some aspect of immune dysregulation.
Great, thank you. If someone had been diagnosed with low IgG later in life and is on IVIG infusions, is there any chance it could be a temporary situation and their body could return to normal IgG levels without infusions? Is this something worth stopping IVIG for and rechecking titers later on?
So so the big answer is that it really depends on the situation. It depends on what you have and depends on what was causing you to have the low IgG to begin with. So big obvious ones, for example, if your IgG is low because it's secondary to something else, then obviously you want to focus on the primary problem. And once you fix the primary problem, perhaps your low IgG will be fixed as well too. If the IgG is due to a primary immunodeficiency, it depends. You're probably not likely to have much change as you get older. But there are some immunodeficiencies that we know of where you can be very severely affected as a young child, and quote unquote, as you get older, it seems to kind of moderate or seem to kind of improve, or your deficiency seems to be less. So obviously the first things first is what is it that you have? I think once we know what you have, we can have a better idea where the natural history of where this immune deficiency is going. And if that is the case, yes, sometimes we will attempt to try to stop the IVIG to see whether the immune system kind of picks up the slack a little bit, or if it doesn't. But you may have a particular immune deficiency where we know, what, it's not going to change. And unfortunately, in that particular case, you may unfortunately have to be on supplementation for the rest of your life.
Thank you. This individual had to stop IVIG due to anaphylaxis. Is this something that's bad for their immune system? They're not getting any extra antibodies. Is there some sort of option for them?
Right. So this is the good thing now in terms of our IVIG. Remember I was telling you that there's like immunoglobulin replacement therapy. We have several different brands, several different routes of administration, and several different products out there, which in essence are all gamma globulin. They're all gamma globulin. They're all pulled from donors, but they all have different additives inside of them. And so a lot of times we think the reactions to the gamma globulin may be due to the additives and not so much the gamma globulin itself here. So if you had a reaction to one option, the first option is to think about switching to a different brand with a different preservative or different additives inside of it, because maybe you may be able to tolerate one more than the other. Or you may change your route as well too. For example, you may do subcutaneous versus an intravenous type of infusion. What was the second half you're asking here? So it's about, yes, if you really needed to get gamma globulin because it was indicated by your primary immunodeficiency, you not being able to tolerate is not a good thing, actually. So we do need to find a way to get you to gamma globulin if it's definitely absolutely needed in your immunodeficiency, basically. So yes, if you need it and you are not able to get it, that would be bad. It would definitely put you at increased risk for infections. So again, it depending on so if people have, the anaphylaxis itself is not obviously acutely not so good, but it's also a sign that you need to potentially switch to a different brand or different product here, but it's not going to affect you in the long run. It's not you're having anaphylaxis on a regular basis or anything like that. But yeah, from an immunodeficiency standpoint, the replacement part of it, if you need it, you need to get it, basically.
Thank you, Dr. Yu. So someone is asking if there are adverse reactions to live vaccines. Why is the Pneumovax utilized as a trial vaccination to see if you can produce antibodies to this vaccine? Is this an antiquated practice or the gold standard?
Well, I don't say it's a little bit of both. So in terms of using vaccinations as a way to assess your function, so we don't just use pneumococcus, we actually use other vaccines as well too. We want to also make sure you have vaccination titers. So for example, diphtheria, tetanus. Now, if you go back in the slides, I think they're recorded, but if you go back and take a look, right, look, we have diphtheria, we have tetanus, we have measles, mumps, rubella, all of those, not just pneumococcus, all of those other vaccination titers are used to assess whether you are able to mount an immune response, and that's the way to assess your function, right? So the reason why we use pneumococcus, because one, if you don't have antibodies to pneumococcus, it does put you at increased risk for pneumonias and upper respiratory tract infections, which is a very common feature of patients with immune deficiency. Two, this particular type of these vaccines are notorious for having people having difficulty mounting responses to them. So if you have a good response, it's a good sign. But if you have difficulty mounting responses to it, it's notorious for just having people having poor responses to the vaccine. So we use that as a way to sort of as sort of like an indirect measure of your vaccine function, of your immune function here. The adverse reactions to chickenpox, that's a different situation. We're not looking at that to see whether you're responding to the vaccine. You can respond to the chickenpox vaccine, but the issue is that if you respond, but you also get the infection, that's where the red flags are basically. Whereas with the pneumococcus vaccine response, we're using that as an indirect measure for whether you are able to mount an immune response. And again, it is a little bit of a question like, well, why do we use that if my problem is not the pneumococcus? My problem is a viral infection. Like, why are you using this? Well, I guess for a lack of other ways of assessing immune system, that's what we're using here to kind of assess the ability whether your T cells and your B cells can interact. So I hope that kind of answers a little bit roundabout way, but there's two different questions that were kind of embedded in that. The adverse responses to vaccines is separate from mounting an immune response to the vaccine, basically. So what I'm trying to get at here. So
yeah, thank you, Dr. Yu. On the same kind of thread talking about vaccinations, someone is asking, how can you differentiate between vaccination titers and what has been integrated into the individual who's on regular IG replacement therapy?
Very difficult because when you get immunoglobulin replacement therapy, you are getting other people's vaccination titers, basically. So once you go on that therapy, we really can't check those vaccination titers. Now, however, there are some exceptions. There are certain vaccines that we can still vaccinate you and check titers for example, like rabies. So those are vaccination titers that are not typically present or commonly present in the general population. And so we could potentially vaccinate you while on your gamma globulin replacement therapy, vaccinate you and see whether you respond to that. So yes, if you are, these are commonplace vaccinations that most everyone gets. Once you're on the immunoglobulin therapy, we don't even bother checking because we know what we're getting. What we're checking is other people's vaccination titers. But there are a few that we can do that we can vaccinate you with that we can check your vaccination response to while on gamma globulin therapy. And those will be the vaccines that people typically do not get often in the general population.
Thank you, Dr. Yu. Another vaccine question, and someone is asking, have you ever seen anyone with CVID get swollen salivary glands after receiving, they say the Moderna vaccine, but I'm sure anybody receiving any type of vaccine has experienced some sort of something afterwards.
Yes. I mean, it can happen. I mean, if you think about you have to wonder with the salivary glands, or is it the salivary glands, or is it something with the lymphocyte tissue, right? The immune tissue that's in those, that's near the glands or in the glands. Yes, well, it kind of makes sense because if you get any kind of vaccine, right, that's what the point of the vaccine is, to stimulate your immune system, basically. And so we do often tell people sometimes your lymph nodes will get a little bit big after you get a vaccination, because that's a sign of immune system trying to ramp up to respond to the vaccine and do its thing, and to train the immune system to say, hey, you know what, this is a bad microbe. All right, I got to train all of you guys to remember this microbe and be ready the next time you actually see it again. So we do sometimes see, people will say sometimes they're like lymph nodes in the armpit, sometimes will swell up a little bit. It should be transient, but if it's persistent and it doesn't, or it takes a long time for it to go away, then yes, it may be part of your immune system being a little dysregulated and not able to kind of pull itself together in an appropriate time frame after a vaccination. So,
thank you. If a patient had whole exome sequencing, do they need whole genome sequencing? Would it help, especially if they had variants of uncertain significance?
So not necessarily. If you have a whole exome sequence and that whole exome sequence found variants that we think that logically make sense, explain what you have, then it may not really make much more difference. It may not really help to get the whole genome sequencing, because one, the whole genome sequence will find what you found with the whole exome, and it may not add extra information. The question will be, if you do the whole exome sequencing and you find these variants and they still don't seem to make sense with what you have. So this is where it gets people don't, well, there's a little bit of explanation here. So people think, oh, once you find the variant, it makes sense. Like, you know exactly what it is. Well, not necessarily. It's just because we say there's a change in the genome here or here or here, we still have to make that change. We have to somehow figure out whether that change relates to what you're having, basically. And oftentimes what ends up happening is people do what we call functional studies. We have to see what pathways it's involved with. We have to make sure that it makes sense for what you have. But if it does, if you have these particular changes on your whole exome, and we think it's affecting pathways that have nothing to do with what you have, then we have to look outside the box, aka look in your home genome to see whether there's something else in another part of your DNA sequence that could be contributing or causing what you have. Does that make sense?
Yeah, thank you. We have a couple people asking about IgD and if we know any more about what it does or how it functions, or if there's any research being done on IgD.
IgD. I mean, there are immune deficiency, there are hyper IgD syndromes here. So it's a smaller class of antibodies. So we don't typically check it unless you have the particular features or symptoms that would suggest us to check that particular antibody class. So as far as I'm aware, there's not a whole lot, more research on this that we know about. I think we also need to gather more patients and gather more information on that. So if more patients present with hyper IgD syndromes and they have the symptoms, I think that can help the immunology researchers say, okay, so we have these symptoms. Why is this symptom occurring? Because of immune deficiency? And they'll have to make that kind of like that, like I said before, like this link between your basically your basics your biology and your clinical features. Like, they have to make that link basically. But yeah, we don't typically check that because it's not a major class of antibodies unless you specifically have something that suggests I have this particular disorder.
Someone says they have CVID and were also recently diagnosed with Ehlers-Danlos syndrome, as well as mast cell activation syndrome. These are autoimmune and genetic conditions. Are they related to immune deficiencies? Is there some sort of connection between all of these diagnoses?
So I would have to, so the way I would put it is I would say patients with Ehlers-Danlos and the MCAS, a subset of patients can also have at the same time immunodeficiency. I don't necessarily think one is causing the other. They can run together. They can have some overlap. That doesn't necessarily mean one's going to automatically imply you're going to have the other. So I think that's the best way I would explain it. It doesn't mean that just because the mutations that are causing EDS are necessarily the same mutations that are causing your immune problems, but you can have both at the same time.
Mm-hmm. Thank you. Is it common for primary immunodeficiency patients to develop allergies to multiple classes of antibiotics?
So it can be common for patients with immune deficiencies to have allergies. So you can still have food allergies. You can still have cat allergies. You can have dog allergies. You can have all these other kind of allergies. So you can also still have drug allergies. So that's the basic part. Now, in terms of trying to get this person to ask multiple drug allergies, that would have to be evaluated because to see whether, first of all, I think the bigger question is like, do you actually have multiple drug allergies? And I'm going to put here in air quotes here, drug allergies, right? So the question is it a true allergy or is it drug intolerance, or these are adverse effects to drugs that you're experiencing? So that first needs to be defined initially, and then from there you can determine what to do with that. But yeah, if you have immune deficiency, can you have other problems that are caused by other parts of the immune system? For example, allergies, absolutely, you can have that.
Mm-hmm. All right, this next question is really going to test my medical terminology, but someone says that they developed superficial thrombophlebitis post-IVIG. Is this an absolute contraindication for any IG replacement therapy, or is there something else available that may be a possibility?
So I'm going to assume that probably that gamma globulin was infused IV, which is how and so that's a type of inflammatory disorder in the vein, basically. So if that was infused through the vein, then we obviously might want to think about doing a different route of infusion, for example, like a subcutaneous route of infusion. That would be sort of the big kind of first line kind of management way of dealing with it. So yes, there can be ways to get around it for sure. And also people are looking at, for example, getting shots, gamma globulin shots. So you can get a shot like once a day. You get a shot maybe once every couple of days, not through the vein, but just a shot basically. So there's a few other routes that you can use to get your gamma globulin besides through a vein.
Someone is wondering if there are other options for patients with intellectual disabilities who don't tolerate IV lines and want to pull them all out. Are there other options to infusing IG, or is there something that can be done to help teach them tolerance of infusions?
Yeah. So just as I mentioned before, so there's subcutaneous and IV are probably the two major routes. But there you can also give, for example, subcutaneous, you can give it and instead of just having like an infusion where you put the needle in you and you infuse it over like an hour or two, which means you have to sit there for an hour or two, right? But there may be also ways where you can give smaller doses on a more regular basis. Yes, it means more injections on a regular basis, but giving smaller doses means that it can go in faster. So it's less time attached to something like a tubing or so on and so forth, basically. So you may hear about, so just to explain again. So people get IV doses usually like once a month. They get it every 2 weeks or so, whatever it is. Subcutaneous infusions are usually often given every once or twice a week, but they are also looking at, for example, giving these infusions once a day or maybe once every other day. What's helpful with that is that you split these larger doses that take forever to infuse into smaller doses. So it's quicker to get into you. So you don't have to be stuck attached to something for hours and hours on end, basically. So those are options that people are looking into. And sometimes actually for some people may actually be a better way because getting it more regularly, you may actually have a more even keel, like a more even level of your gamma globulin in your body than getting it every 2 weeks. So but yes, there may be some ways to do to kind of manage that, especially someone who can't tolerate IV lines or subcutaneous lines. In terms of getting teaching, oftentimes we refer to the infusion nurses are the ones that have the tricks. They know, they worked with various patients and they know the tips and tricks on how to kind of either move the lines, hide the lines, or anything to kind of distract the patient. I leave it to them to kind of help you with your infusions, because it obviously depends on how you're infusing it, where you're infusing it, how your setup is in your home. So it all will really depend on that versus just giving a general kind of guidance on that. So.
Very helpful. We do have just about 4 minutes left, so the questions keep coming, so I'm going to try to go as quickly as we can. Somebody is wondering that they have heard that hyaluronic acid is being used for treatment. How does this work, and is this something you might recommend?
So that there is a form of gamma globulin that uses the hyaluronic acid. It's almost facilitated gamma globulin infusions, basically. So the hyaluronic acid, let me clarify, that's not treatment. It just helps to facilitate the infusion of the gamma globulin. So what it does is sort of locally breaks down the tissue in the area where you're getting the infusion. So it creates a bigger area underneath the skin, so for more of the gamma globulin to go in. Because one of the issues that we get is like when you're infusing underneath the skin, there's very little area between the top of your skin and the bottom of your skin, basically. So oftentimes there's things that kind of ooze back out again. So by opening up the area and kind of opening up so there's more of the product can get in, it helps facilitate getting the gamma globulin into you. The hyaluronic itself in and of itself doesn't treat immunodeficiency per se, but it does help with infusions being more efficiently, getting into you more efficiently, perhaps more quicker, and with less potentially, like maybe even like less side effects in terms of like less of the balling up underneath the skin. So
Very fascinating. How frequent is it that someone with a PI has others in their family who also have a PI?
So, repeat that question again.
So how frequently does it happen that somebody with a PI also has other family members with a PI?
Oh, okay. Yes. So it can happen. And it actually is very helpful for your doctor if they know this. So this is part of the clinical history, right? So not just about you also, it does help us for you to also document what's happening with your family members, okay? So it's not, you can't just come in a vacuum on your own and say, hey, what about me? It's, what about the rest of your family? How is the rest of your family doing, basically? But yes, we do see that sometimes that someone comes with a known family history, and that really helps us because, especially if you are thinking, especially for the children or expecting for family planning, that can be helpful. Now, but on the flip side, there are many patients that do come in without known family history. Now, I'm going to put down here without known. So the word is known because maybe they do have something that just hasn't been diagnosed yet, or they haven't presented themselves to a doctor to get the diagnosis yet. And so it's arguably that maybe, as we all know, there's a very long delay between when you start having your symptoms and when you get your diagnosis, especially for patients with immunodeficiency, right? Because you end up having to accumulate many things before you finally say, aha, that's what I have. And so I think there is a little lack of underdiagnosing primary deficiencies. And so I would say, if we had better ways of diagnosing it, maybe more patients would come to us with saying, I have a known family history of X, Y, and Z.
All right, we'll do 2 more.
Okay.
What, Oh no, it just disappeared. Okay, hold on. Let me find it. I was getting too quick with my
Oh,
my button. Can you have CVID and MASP2 deficiency? This individual had whole genome testing, which showed an MASP2 deficiency, but they've already been diagnosed with CVID.
yeah, I mean, so a couple of things here. So CVID, we used to think of it as an actual disorder, but we actually think of it as more of it's, how do I say, it's not really a disease in and of itself, because many CVID patients now have known genetic diagnosis for what they have. So I think it's almost, we call it like a phenotype. So meaning like what the status of the immune system is here. So common variable immune deficiency means suggests that you have some issues with your humoral, your antibody deficient, your antibody part of your system, and also some issues with your cellular part of your system, and potentially even other parts of the immune system. So that's what common variable CVID really kind of refers to, actually. So you can have a CVID phenotype with almost any sort of PID as well. So I mean, certain PIDs are very specific depending on the pathway, but if you a lot of antibody deficiency disorders may have this label of CVID, but you can also have it with other immune deficiencies. And actually, separate from that, we have patients with multiple immune deficiency, like for example, someone who have the George and they can have another type of immune deficiency at the same time. It all really depends on what your genetic mutations are.
Thank you, Dr. Yu. All right, last one. This individual has CVID and they have had elevated NK cells for the past several years. What are some causes for something like this?
For the increase, that's an excellent question. So we don't know. So I think the bigger question is, are the elevated NK cells, are they elevated because of something else? You know, are they becoming the driver or the outcome, basically, right? Are they abnormally high because they're abnormally high to begin with? And what is the outcome of that? Or are they abnormally high because in response to something else, basically? And so that would have to, you would work it out with your immunologist to determine, like, what other issues, other features it has. So don't just look at the NK cells. You look at the bigger picture to see where it would fit in, and to see whether it's part of some other bigger picture, or is this the initial thing and then all these other things happening below it, basically. So it really would depend. So we can't just say it's because you have increased NK cells that we know exactly what you're going to have.
Awesome. Well, thank you, Dr. Yu. I'm sorry to say that is all the time we have for questions. We had over 50 questions written in, so I'm so sorry we couldn't get to everyone. You're always welcome to ask IDF, where you can ask your very particular question and you will get a response from a member of our team. And you can do that on our website at primaryimmune.org. So thank you so much to Dr. Yu. It has really been an honor to have you join us today. This session is one of just 39 unique learning opportunities that are being provided through our 2023 PI conference, and we are just getting started. So I hope you'll continue tuning in today as we explore other critical topics with the PI community. And I also want to thank again our partner CSL Behring for supporting this webinar and part of our conference today. So thank you again, Dr. Yu. Thank you everyone for joining and submitting your amazing questions. We'll see you around on this virtual platform. Have a great day.
Thank you.